Hi, my name is Kavel Visrodia. I'm a fellow in the Division of Gastroenterology and Hepatology at the Mayo Clinic in Rochester. On behalf of my co-authors, I'd like to thank the editors of Gastrointestinal Endoscopy for this opportunity to speak to you about our publication titled Cryotherapy for Persistent Barrett's Esophagus After Radiofrequency Ablation, a Systematic Review and Meta-Analysis. Barrett's esophagus is well recognized as the precursor to esophageal adenocarcinoma. The risk of progression is particularly high in those with dysplasia, so treatment is recommended. Radiofrequency ablation, or RFA, remains the first-line therapeutic option because of its excellent efficacy and safety profile. In fact, up to 80 to 90% of patients can achieve complete eradication of Barrett's with an RFA treatment program. However, in that small remainder of patients who don't respond to RFA, the optimal management hasn't been defined. Cryotherapy is an alternative ablative technique that's cold-based as opposed to heat-based like RFA. There are 3 cryotherapy systems currently available in the U.S. for the treatment of Barrett's. 2 of the systems involve a through-the-scope catheter used to spray the cryogen directly on the target mucosa and require a tube for decompression due to cryogen gas expansion. The third system involves a through-the-scope balloon in which the cryogen is contained and the gas dissipates back out through the catheter, obviating the need for a decompressive tube. In general, cryotherapy appears to penetrate tissue deeper than RFA and perhaps with a lower risk of esophageal stricturing. Now, there's a slowly growing body of literature describing the use of these cryotherapy systems for second-line therapy in Barrett's patients who don't respond initially to RFA. So to better understand the efficacy and safety of this practice, we performed a systematic review and meta-analysis of the currently available literature. With the help of an experienced librarian, we performed a literature search and specifically included studies of 5 or more subjects with Barrett's dysplasia who were treated with an initial course of RFA but had persistent Barrett's and went on to receive cryotherapy. Our aims were to determine the pooled proportions of patients achieving complete eradication of dysplasia or complete eradication of intestinal metaplasia with cryotherapy. Overall, 11 studies and 148 patients met these criteria and were included for analysis. All studies were performed in the U.S. and were relatively small, with all but one study having fewer than 25 subjects. The pooled proportion of those achieving complete eradication of dysplasia was 76%. The pooled proportion of those achieving complete eradication of intestinal metaplasia was about 46%. These were associated with moderate to substantial heterogeneity, which wasn't sufficiently explained despite multiple pre-planned subgroup analyses. Adverse effects were reported in about 7% of patients, the majority of which were esophageal strictures, and fortunately amenable to endoscopic dilation. There were some notable limitations with this meta-analysis. The overall size was relatively small, and this supports the excellent efficacy of RFA in the vast majority of patients with Barrett's. Also, we aggregated the experience with all 3 available systems of cryotherapy, so treatment protocols varied and likely introduced heterogeneity. There's also no consensus on when a patient is deemed to have failed RFA, so the threshold to switch to cryotherapy varied among studies. Also, only about a quarter of studies were published in full text at the time of our review. Nonetheless, subgroup analyses based on many of these variables didn't identify any sources of significant heterogeneity. And so in conclusion, we've found that approximately 3/4 of patients with Barrett's and dysplasia who don't respond to initial RFA go on to achieve complete eradication of dysplasia with cryotherapy, and about half of patients can achieve complete eradication of intestinal metaplasia. Cryotherapy appears to be an effective and safe second-line option in this difficult-to-treat patient population, but higher quality studies are necessary validating these conclusions. Thank you again to my co-authors and the GIE editors for this opportunity, and thank you for watching.